Dr. Monica Christmas. I am the director for the Center for Women's Integrated Health and the Menopause program at the University of Chicago. I have been practicing, I finished residency in 2005, I think it was. So many years. It doesn't seem like that long though. I still feel kind of young, but I'm not. So I think really it should be, everybody should get the same questions. Everybody should get the same welcome when they come to sign in at the reception desk, right? They're given their little iPad, or if people are still doing papers, however you're having people check themselves in. Most of us do it electronically now. But asking, what do you like to be called? What are your pronouns, right? So you ask everybody the same question, so then nobody has to feel different, right? Everybody has on their badge what their pronouns are. That tells me as a patient, oh, these people are receptive, like I can share what mine are, right? And I think if you make a mistake and you get it wrong, right? You accidentally refer to some, use a pronoun that is not what the patient identifies as, you can apologize. So most people appreciate that. Nobody expects perfection, but what people want is respect. And I think the second part about it is that it is, if you aren't knowledgeable, being able to have a good referral basis for your patients. We are not expected to know everything. Some of us have a very broad level of expertise. Some of us have a niche that we work in, but being able to have resources for patients so that if they need something that you actually can't provide, you have a network of providers that you can expose them to. One of the best things I think that came out of the COVID pandemic is this pivot to virtual care that doesn't seem to be going anywhere. And so even in your town or your place of practice, if you don't have a good referral network, you can create an international one now, and people have access to resources, to counseling resources that we didn't have before from a virtual format. Many of the patients that I'm seeing that are opting to either have suppressive medications where that suppresses ovarian function. So it pretty much suppresses your estrogen production, puts you in a temporary state of menopause while you're on those medications. Or some patients, as I mentioned earlier, are opting for having a hysterectomy with removal of their ovaries. And so when you're talking to very young people that are remote from the natural onset of menopause, about putting them into not just a short-term state of menopause, but permanently, or, in the state where they don't have estrogen, it impacts their bones, it impacts their cardiovascular function, impacts cognitive, and increases their risk of dementia in the future. And I think those are really important conversations to have with people making those decisions, because some may decide then maybe I won't have my ovaries removed, and maybe that will be at a later time. I didn't recognize that those were adverse health outcomes that I could have. If somebody who wasn't undergoing gender affirming therapies went into premature menopause, it's automatic that we would then supplement them with hormone therapy, right? Estrogen and progesterone. If they didn't have a uterus, just estrogen. But in somebody who really is trying to block the effects of estrogen and they don't want that, it becomes a really challenging conversation. And where it becomes extremely important, and I don't have the data behind this because it's not there. I'm working with some individuals to get more information so that we have more data and research in this patient population, but we don't have it right now. So it becomes really important to talk about lifestyle interventions and saying, hey, you are at extreme risk of developing osteoporosis that increases your risk of fracture with morbidity and mortality is high. So what are ways that we can do to make sure at this point forevermore that we are increasing bone density, right? Are you adhering to a diet that's high in calcium? Are you engaging in weight-bearing activities? Those are things that you can do to help maintain bone density. And then we've got to screen, right? So normal screening might not start for somebody without risk factors until 65, I think is the age now, earlier with risk factors. So this is a population with high risk factors. And so if we start to see that they have decline in bone density, we need to start to treat them much earlier to try to mitigate those risks. Same thing for cardiovascular disease, really impacting and stressing early the benefits of exercise and adhering to a heart healthy diet, and being really proactive about screening them as well, especially if they are going without estrogen for long periods, whether it be because we took the ovaries out or medication. Same thing goes for cognitive decline, of being able to be mentally and physically active. The same things we would tell our older patients. We don't think about telling somebody in their 20s or 30s or having these conversations, but when somebody is thinking about going into menopause earlier than normal. And then it's all of the pesky symptoms: hot flashes, night sweats, vaginal dryness, that may impact sexual function, increased risk of anxiety and depression, especially when there's so many other factors going on in that person's life that may also be increasing depression too. Sometimes we lump hormone therapy all in a big basket, and we think of it all being the same thing, meaning like hormonal birth control is the same as hormone therapy, and it's different. And so I think sometimes that helps too, when I explain that, when I'm giving you hormone therapy to help with your to prevent your premature menopause from surgery impacting your bones, your brain, your heart, I'm just getting you back at like a physiologic level. And that may not have the same side effects that you might have experienced if you were on some form of hormonal birth control in the past, because people kind of identify with that. I had horrible symptoms. It made my depression worse. It made my anxiety worse. It gave me breast tenderness, and breast tenderness in anybody is not a great side effect, right, for anything. But in somebody who really, that part of their body is something that they would like not to be there, that can be even more stressful. And so I do try to explain that, hormone therapy dosing is very different than what you might have been on for birth control dosing in the past. And most people don't have those same symptoms